Welcome to the Australian Genomics First 5 Years webinar. I'm Tiffany Bortwood, I'm the Manager of Australian Genomics. We're coming together today from all across Australia, lands traditionally owned by Aboriginal and Torres Strait Islander people. We acknowledge these traditional custodians and recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. And Australian Genomics is committed to ethical, equitable and inclusive research that benefits all Australians. This week on social media, we've been reflecting on the past 5 years of Australian Genomics, showcasing some of the many outcomes of our research that has informed how genomic testing can be embedded in Australian healthcare. This research could not have been possible without the thousands of participants who generously contributed to the study, enrolling in clinical projects, doing surveys, donating data, and providing feedback. Today is about you. To thank you for your involvement in this important research and to share some of the impact that this research has had and to give you the opportunity to ask questions of some of the people involved in Australian Genomics. Before we get started today, I've just got a little bit of housekeeping. So you'll see at the bottom of your Zoom window a Q&A link. Please feel free to ask questions by typing into the text box there through the Q&A link. The Zoom chat function will be disabled throughout this webinar. Feel free to start asking questions, adding questions any time from now, and they'll all be addressed during the Q&A session later. We'll get through as many of the questions as we can, and we'll see if we can answer some of those after the event. A few little rules of engagement, apart from please, be involved and ask lots of questions. We ask you to always use welcoming and inclusive language and show courtesy and respect towards other attendees when you're typing questions in that link. Also, just to note, we have hundreds of registrants today from researchers, from industry, health professionals, policymakers, and also our people who've participated in research and family members of those participants. So we'd ask that when you're typing questions for the Q&A later on, that you just consider this mixed audience with your questions. This event will also be recorded and made available on our Facebook link, so you can check back in later on. We'd like to start today with a video that explores some of the potential of genomics and the impact of that from the perspectives of patients, of health professionals and family members. So I'll link to that video now.
Declan Holmes is a 17-year-old from Batemans Bay, living life to the full, excelling at school and loving sport.
In my spare time, I enjoy playing rugby union for my local club, the Brownlow Dolphins. I've always enjoyed playing sport and doing physical activity.
But in his early high school years, Declan found his legs were failing him.
But something always seemed to be not quite right. I didn't seem to have the same level of balance or strength as everyone else my age. This problem continued to exacerbate as I got older.
Endless visits to hospitals and doctors followed, but there were no answers.
My family had tried lots of things to help me with my movement over the years, and we'd talked to lots of medical practitioners and medical people about what might be causing the problem. Most people told us that I'll grow into my legs soon and it will improve as I get older and start strength training, but this never really happened.
A doctor sent Declan for an MRI and spots were found on the white matter of his brain. Declan was moved to the Children's Hospital at Westmead and diagnosed with unknown leukodystrophy, a condition that affects the brain, spinal cord and nerves and can lead to death.
And that was the original outlook, was that I was likely to pass away within the next sort of few months during my original diagnosis, which was really, really brutal for my family and friends and for myself.
But Declan's neurologist wasn't satisfied with the diagnosis, so enrolled him into the Australian Genomics leukodystrophy trial. The genetic experts searched his 22,000 genes and found Declan had an extremely rare condition. He was the first in Australia to be diagnosed with this new gene mutation.
The results were good because they gave my problem a name. It's called VPS13D spinocerebellar ataxia. This is obviously named after the gene, as that's not a very catchy title.
Not a catchy title, but Declan's prognosis is not fatal. Now he's focused on getting on with life, being a teenager and managing his condition.
Without the genetic testing, we would not have known this. Because his imaging, his MRI scans of his brain do look like a leukodystrophy. It's the genetic testing that's clarified things and given his family and his doctors certainty of what he's got.
Australian Genomics has helped thousands of people like Declan through its 21 flagship research programs. By searching through the body's DNA, our genetic code, Australian Genomics has been able to identify, sometimes within days, diseases that have baffled other medical experts for years. And all that's usually needed are blood samples. The need for a swift diagnosis is never more urgent than when a child or baby is in intensive care. Another Australian Genomics program, the Acute Care study, is giving the sickest children access to fast turnaround genomic testing. These tests aim to pinpoint the source of the problem in the body's DNA, and results can be delivered in just days to worried parents.
Families are hugely distressed when they have a baby or a child admitted to hospital with critical illness, and there's a great period of uncertainty and anxiety. So we have been able to shorten that period considerably for many families.
A precious diagnosis explains why the child is sick. It enables the condition to be managed, treated, even cured. And it can also reveal the risk of future babies being born with the same problem. The Acute Care study is now being rolled out across Australia. And for the first time this year, some genetic tests have been listed with a Medicare benefits schedule, meaning costs running into thousands of dollars will be reimbursed for the families of children tested for childhood syndromes and intellectual disability.
And so now they are much more used to the concept of genomic testing and its potential implications in the rare disease space.
This is paving the way for more government subsidies of genetic testing, and parents couldn't be happier.
Genomic testing has cost-saving benefits to the healthcare system, but it also supports parents' mental health. When you finally get an answer, it's like a weight has been lifted from your shoulders.
A key advantage of genomic testing is that it can spare people with undiagnosed conditions a barrage of invasive tests like lumbar punctures, biopsies, and countless blood tests.
And I think during that hospital test I had every sort of test you can imagine. I had bloods, spinal, nerve conduction and more MRIs. The doctors and nurses were amazing and always tried to keep me smiling.
But no one wants to be on an endless quest for answers.
Genetic testing was easy compared to the other tests.
And an ever-growing number of hospitals and medical experts are now offering genomic testing. Australian Genomics is delivering answers to people who've been searching for years, bringing their diagnostic journey to an end.
It's been really beneficial for me to have access to this trial at Australian Genomics because it's helped bring peace of mind to me and my family and friends.
Now it's my pleasure to introduce Professor Kathryn North, the lead of Australian Genomics. Kathryn trained as a child neurologist and clinical geneticist, is director of the Murdoch Children's Research Institute and vice chair of the Global Alliance for Genomics and Health. Kathryn has not only led Australian Genomics, but has been instrumental in genomic medicine and research in Australia, for which she was recognised with a Companion of the Order of Australia. Kathryn, over to you.
Thanks so much, Tiff, and welcome to everyone. It's so wonderful to celebrate 5 years of Australian Genomics. What I'm going to give you an idea of today is the scope of the work that we've done. And particularly when we started in 2016, so 5 years ago, we were really aware of the challenges that we're facing in terms of rolling out genomic medicine around the country. What we're also aware of is that as people were starting to look at the implementation of genomics, there tended to be around the different states and territories, different efforts going on, some duplication of efforts. And we really wanted to make sure that this was not growing up in a fragmented way, that we were pulling together the country. So the challenges that we're facing, we're working in silos, often because we have state diagnostic services. The access to funded genomic tests was very ad hoc, and actually back in 2016, very little was funded apart from single gene tests. Genomics was also happening in research rather than within clinical practice. And I know I've got a long history in looking at gene discovery for rare disorders. But if you were lucky enough to come into a clinic where you're associated with a specialised research centre, you could get a diagnosis. But how do we take that into clinical care to benefit many more people? There was also a lack of evidence about the effectiveness of testing for different conditions. Wait times for results were very long, and we've heard just in that wonderful video about the diagnostic odyssey and how sometimes patients and their parents and families were waiting months, years, or sometimes forever to try and get a diagnosis. There's then this need to share information about genomics amongst many centres, not only around Australia, but throughout the world, because we need the information on hundreds of thousands or even millions of people to be able to make an accurate diagnosis in a rare disease. And there was also, because this was a new and disruptive technology, that the patient experience and the approaches to consent really varied from centre to centre. So the goal of Australian Genomics was to address these major challenges. And what I'm going to talk to you about today is what I regard as 5 of our biggest achievements that are addressing these specific challenges. First of all, the first thing we did was bring together around the country all of the clinical and diagnostic services that were working in genomics, plus all of the major research centres that were doing research in genomics, because there's always going to be a virtual cycle, or a virtuous cycle, in fact, of moving what is discovered into research as quickly as possible into clinical practice. And so bringing the clinicians and the researchers together was the best way to do that. We also knew of what was happening overseas, and so we looked to form international partners so that we're making sure that everything we developed in Australia was international best practice and that we could learn from the mistakes of others. And so as Australian Genomics kicked off back in 2016, we initially had 80 institutional partners. It's now up over 100. And our network has grown to over 450 investigators around the country. It's an amazing collaborative effort, but it's also a major collaboration with all of the patients and the families with whom we've worked, and we're so grateful for that. One interesting thing is we looked at the social network, social by really social working network that we developed over that time. And this was just in the first years. This is actually mapping the interactions between scientists, geneticists, laboratories. And you can see how just over a period of 2 years, those interactions at least tripled, and they've continued to grow to this day. The second challenge we faced was getting genomic testing funded. And really to do that, we needed to convince the government that this was really the best way in terms of bringing a diagnosis quickly and accurately to a family. So a lot of the early research that we did, and was also being done in different states, was to look at what the diagnostic efficacy, or how often we got a diagnosis using a genomic test compared to what was then standard of care. And what was the cost effectiveness? What did it cost? And there's really a landmark study initially that, and the data is based on a study that was done in Melbourne initially, but then really gathering evidence from around the country and internationally. And what we demonstrated was that if you had standard of care for many rare diseases, the diagnostic hit rate was about 10%. And as we've heard in the video, there was many tests done at huge costs. And we actually came down to a figure of over $25,000 to reach a diagnosis using standard practices. But when we introduced a genomic test early on in that diagnostic workup, we got 5 times the diagnostic rate. So we hit a 55% diagnostic rate, and the cost was markedly reduced. It was down to around a quarter of the cost of what we were seeing from standard care. So using that evidence, which was supplied by great work from clinicians and researchers working together, we made an application to MSAC that was led by Australian Genomics. And that's where we go to government to say that this is something that is really worthwhile doing. And it was approved in August of last year. And in May this year, the first subsidised genomic testing was launched, and now that's funded by Medicare. And so this was particularly focused on childhood syndromes and also kids and families that were experiencing intellectual disability. And this testing alone is expected to benefit over 3,000 families a year. And we now that we've worked out and we're working with government on those processes, we're now involved in applications related to the better diagnosis of epilepsy, of renal, of heart disease, and of muscle disorders. We're also working on reproductive carrier screening, which means how do we screen potential parents to look if they're at risk of having a child with a major or disabling disorder. And we're also working again with the government to how this may become more widely available. The next challenge, and as you can see, we need to provide this evidence to government to engage them to support the funding of genomic testing. And so we ran a number of clinical flagships, and you can see in this list it crosses a whole range of rare genetic disorders, as well as cancer diagnosis. And through these pilot studies, we were able to look at, again, the improved cost effectiveness for diagnosis, but most importantly, how much more often we're able to give a diagnosis to families. Across all of those different rare disease flagships, the diagnostic rate was increased from about 10% to 36% overall, but there's a wide variation there from 30 up to some disorders getting a 70% diagnostic hit rate, which is a major rapid achievement. For some cancer types, our genomic testing was providing information that was very relevant to the management of those patients in 85% of cases. So this also has made a major difference to how we apply the genomic diagnosis to better treatments for specific cancers. You've heard a little bit about acute care genomics, and really when we started this, it was certainly months or even years for the results of genomic testing to come through. And obviously that's not what we need when we've got critically ill kids in intensive care. And that's been the focus over a number of years of how quickly can we do a turnaround time. We got down the months initially down to weeks, but now we're routinely getting a 3 to 5-day turnaround for genomic testing for our sickest infants. There was a first study that looked at and worked with over 12 hospitals around the country and many neonatal and paediatric intensive cares. And the first 100 children that were tested, we got a diagnostic hit rate of over 50%, which usually with standard care of critically ill kids in ICU is really far less than 10%. Most importantly though, in 3/4 of the kids, the genomic testing resulted in a change in their clinical care to be much more focused, much more precise. This is really the development of precision medicine. And most of the test results were returned within 3 days. The next phase of this has just started this year, and this has been funded by the government through the Medical Research Future Fund, and plus some philanthropy and coordinated through Australian Genomics. And now we're rolling out this acute testing for our most critically ill children all around Australia, involving every state and territory. And this ultra-fast testing has got a full national approach. And I'm very proud to say that we are the first country in the world that has taken a national approach to this type of rapid testing. And there's also, because of what we've set up with the networks around the country, this got up and running in record time. From the funding being available in July, it was up and running within a month, which is incredible. The next challenge relates to how do we share our knowledge about which changes in the genome are associated with disease and which are just normal variants. So what I mean by a variant is, we are all different. And in actual fact, if, say, Tiff and I compared our genome, there'd be a lot of variation between it because she's obviously much taller than me, we look differently. All of those things are related to what are normal genetic variations. But when we're looking at disorders like rare disease and cancer, we're really looking for the variants or those changes within the genetic code, particularly spelling mistakes or words that are missing. And it's that information where we need to know, is this associated? If we see this in a patient, do we know that's associated with disease? How definite can we be about the diagnosis? And in clinical practice, you need to be as absolutely sure as you can, based on as much evidence as you can get. So the initial work that we've done, and it's got the great name of Sharient, is that we've worked with pathology labs around the country and developed a way of capturing that genomic information and also all the work that goes on behind the scenes to interpret that based on evidence to make a call as to whether a particular spelling mistake, for example, is disease causing or not. And now we've developed this rapid and automated process so that information is collected around the country. And importantly, it is shared around the country, but we also plug in to the international knowledge bases as well. That way, we can bring the knowledge from around the world that is relevant to a patient. We can take that from anywhere and apply it in a clinical setting. And that makes a huge difference and also really speeds up how good we are at making the most accurate diagnosis. And, just in the last week, we've got this great example from the Victorian Clinical Genetics Service, and it was sharing of information between two Australian laboratories about a specific very rare disease and a very rare genetic change or variant that allowed us to make a diagnosis of a heart condition in a family within a matter of weeks. This result will guide the treatment of the family, but it will also aim at preventing long-term complications. And we're making that learning and that information available around Australia and also around the world. Finally, I think, really paramount of everything we do is an ethical approach to genomic testing to make sure that an individual's privacy is protected, and making sure that families and patients that are going through this testing have the best experience and are fully informed. Now, when we started, there were different consent forms and different approaches to consent around the country. And what we've done is work with our colleagues around Australia to develop a clinical consent form for national use. And that's been endorsed by Genetic Services, and it's currently in use in 12 locations around the country. And the work that we've done here is also being adopted internationally. We have an amazing community advisory group, which I'll come to, it's also providing plain English information for patients and the public about genomics. COVID has really changed many of our practices, but we were able to put rapidly into place the practices to use telephone, e-consent, to use videos, to maintain recruitment and maintain a really personalised approach to providing information to families about their genomic testing. And we've developed Control, which is a wonderful computer platform for dynamic consent. And what that means is that it enables you as patients or participants in studies to actually interact and be very specific to what you consent to and how you're willing for your information to be shared to help diagnose others or to be shared for research. So this whole process is about empowering the individual who owns their genomic information to make sure that it's used in the best possible way and with their consent. And it's also a great interactive way to getting ongoing information about your genomic information going forward. Again, as part of our international collaborations, this approach that we have developed here is being adopted in a number of initiatives internationally. I mentioned our consumer and community advisory group that's been ably led by Richard Vines, and you can see it covers a whole different range of organisation and advocates. We work in partnership and co-design what we do with our community advisory group, and they're very, very wise. We also, through our community advisory group, have engaged with patient and parent advocacy groups around the country so that everyone is engaged in the process and can really signal what is most important to families and patients as they're facing the diagnosis of a genetic disorder and how that is influencing their care and how it's influencing their therapies. So the patient voice, the community voice, is really at the heart of everything that we do. So I'm now going to hand back to Tiff, and we have a wonderful video to really give you a feel for this patient journey around these 5 big challenges and how you have certainly helped us to get invaluable answers that are helping many, many more people around the country.
This is Sam. Sam has a medical condition which has been difficult to diagnose, but doctors think the answer may be found by looking at her DNA. Her doctor invites her to participate in a genomic research study that is available. After thorough explanation of the study by a genetic counsellor and careful consideration, Sam chooses to participate. Sam provides a sample for the research, which is sent off for genomic sequencing and analysis by scientists. A big group of scientists, genetic specialists and other doctors may meet to discuss Sam's results and, using their collective expertise, work out what the results mean for Sam. They take into account things like family history, Sam's symptoms, and how much is known about the gene changes that were found during the test. The results of this analysis form a report that is explained to Sam by her doctor or her genetic counsellor. The report is clearly explained and outlines any implications for Sam or Sam's family. If a result can't be explained or a diagnosis can't be found for Sam, her genomic information may be shared with other researchers who may reanalyze the data or do laboratory experiments to understand what the change in Sam's gene may mean. As well as providing this information for Sam, the data from the test are placed in secure databases where they can be used for further research. This may find more information for Sam. By linking Sam's medical information or symptoms with her genomic testing information, researchers can piece together how a certain genetic change is likely to affect the body's functioning. This is information that can help other people who have that same genetic change. This collection of data can also help researchers make new discoveries about diagnosis and treatment for people like Sam. These people might be on the other side of the world. Once Sam fully understands her results, she is asked to complete surveys on her genomic testing experience. Sam may only meet a handful of doctors and researchers, but there are many other people working behind the scenes to ensure that Sam and others like her benefit from the information that Sam has shared. The surveys Sam completes help medical professionals and institutions improve the services they provide. The information also helps researchers understand problems and discover new ways of doing things. And it helps genetics professionals communicate better with their patients, so people like Sam understand the impact testing can have on them. One day, not too far in the future, through the involvement of people like Sam in research, we may have worked out what every single gene in the human body does. We will then be able to use that information to benefit all people.
Terrific. Well, hopefully that gives a bit of an impression of the broader network of clinicians and researchers and diagnostic professionals that are part of Australian Genomics that might have been involved in your journey through the research. And this is where we're coming to the panel. So I ask initially, Steph, if you would put on your camera, please. So we're going to be working through and introducing each member of the panel, and they will have an opportunity to say a few words about their involvement in Australian Genomics. And so we're going to start with Stephanie Best. So Dr. Stephanie Best is a health services researcher who's based in Melbourne. Her focus is on the use of implementation science, which is translating evidence into real-world practice and policy. Steph.
Thank you, Tiff, and thank you for the opportunity to join this discussion at such an exciting time for Australian Genomics. As Tiff just said, my area of interest is around seeing evidence that's generated and make it into frontline patient care. But before I go any further, I feel I have to make a confession to all of you. I don't have a genomics or a genetics background. Before I came out to Australia to work with Australian Genomics, about 3.5 years ago now, I had a lot of work to do to find out more about genomics. What are the clinical implications? What does this mean for patients? I should add that I do have quite a significant clinical background as a chartered physiotherapist, and so the patient-centred emphasis of my clinical work extends into my research. And we have a phrase in the UK, and I'm not sure if it's over here or not, but it's nothing about me without me, and really reinforcing that the patient is at the centre of everything that we do. So I'm a health services researcher, and my area of interest is implementation science, as Tiff said, which is about facilitating getting evidence into clinical practice. Now, we know from the evidence that there are lots and lots of medical innovations and discoveries that just don't make it to patient care. And the estimated time for ideas that do make it into patient care is 17 years. So that's 17 years from the discovery of something that could make a change to actually getting into clinical practice. Now, there are lots and lots of people who are focused on discovery rather than implementation, and obviously we get that. But if the conversation about genomics is only focused on that stage of research, well, we're just missing so many opportunities for patients, the general population, for all of us. Keeping our fingers crossed and hoping is not going to be enough. So during my various research projects, I've spoken to quite a lot of clinicians, laboratory scientists, other people who work even further behind the scenes to make stuff happen. And although the topic of the conversations that I'm having with these people vary, there is a constant in the emphasis on the importance of making a difference for patients and families. Now you may well expect this, quite rightly, from frontline staff that you might be directly interacting with. But the impact for the people who are behind the scenes is fantastic. As there was one lab scientist who said to me, you get answers for patients who didn't have one before. That's what's exciting for me about genomics. So I've been extremely fortunate that working with Australian Genomics has allowed me the flexibility to work on projects and with people in and outside of Australian Genomics. Sometimes I just have a cup of coffee with people and we discuss how they could be thinking about bringing implementation into their work. And I do drink quite a lot of coffee. And other times I get my sleeves rolled up and get involved in the project more closely. When you're working in the field of implementation science, the most important step is about understanding the context in which you're stepping into. We need to understand what is important for the people who are involved, what's stopping something from happening, what might help something bring this into something into practice. And I thought perhaps I could give you a couple of examples. So sometimes it's about going directly to the community. So for example, at the moment I'm working with the Genetic Support Network Victoria, and we are collecting monthly journals from people across Australia who are living with a genetic undiagnosed or rare disease. And people are recording their thoughts and experiences as we're living through COVID-19. And what we'll do is we'll analyse this data, and we're going to be exploring topics such as resilience and growth just to see what we can learn about what it is that influences some of those areas. Other times it's more about triangulating information. So, for example, the Australian mito clinicians have been developing guidelines on the best management for people diagnosed with a mito disease. Now, the Mito Foundation realised that guidelines on their own do not change practice, which is just so true. So working with them, we have just completed a series of virtual focus groups with consumers to identify what some of the priority areas are that we need to be thinking about working on. And this information is going to directly influence the discussions that we have with clinicians about what needs to change and how it needs to change. And I've just got one last example, because there are other times when actually we just need to get a whole group of people together, a whole range of people together. And last year, we ran a series of focus groups with patients, clinicians and organisational staff all together in one room, which just kind of feels just another life away, doesn't it? But we wanted to get a consensus view on what's important about clinical genomics for people who are in different spheres and in have different clinical experiences. And we had a pretty healthy debate, which is always good. And then using the data that this group generated, we've undertaken a series of surveys led by my health economics colleague, Ilias Koronaitis, to articulate what people value from clinical genomics. And this information can be used to influence policy and to prioritise activity. So you can probably sense that I could go on, but I feel, I'm sure, Tiff, my time is running out, but just one last thought to sort of wrap up. Here in Australia, we know that discovery research is still really, really important. But if we just sort of remember that 17 years bit that I mentioned a minute ago, the joy of working with Australian Genomics is that now this discussion is regularly complemented with other discussions about implementation, patient engagement, and mechanisms to get stuff to frontline clinical practice. So if somebody was to ask me for one thing that Australian Genomics has achieved, amongst all the things that it's achieved over the last 5 years, for me, it's really been about changing that conversation. Thank you.
Thank you, Steph. That was a lovely introduction to all the many things you're interested in and are working on with Australian Genomics.
Just a little tip of the iceberg there.
Indeed. Now, Adam, now I'd like to invite you to turn on your camera. Hello. So Professor Adam Jaffe works at the University of New South Wales and Sydney Children's Hospital. His research centres around improving child health outcomes for those affected by asthma and cystic fibrosis, childhood pneumonia, and rare lung diseases. Adam.
Thanks very much, Tiff, and thank you very much for inviting me to be here. It's really an honour. So I'm a respiratory pediatrician, which means I look after the children with chest problems. So my expertise really is from here to here. And like Steph, Professor, I really have little understanding of genetics, but thankfully I'm surrounded by brilliant people who do. And I look after a group of children who have a very rare lung condition called interstitial lung disease. So we've called this CHILD for short. About 2 in a million children have this. And their stories will be familiar to many of you out there who have a rare condition. Families that really struggle to try and get a diagnosis, and many don't have a diagnosis. And even when a diagnosis is made, they don't know who to turn to. Where's the relevant expert? In the past, I used to be referred patients from all over Australia by the US Child Network. And then where do they go to for treatment? Are treatments available? And then where do they go to for resources, for education, understanding what the diagnosis means for them, and looking for peer support as well. When they want to talk to families with similar diagnoses, where do they go? So these are the challenges that really set us up a framework about 4 years ago when we really reacted to the needs of the families and patients that we look after. And so about 4 years ago, we set up a community of practice. What this looks like is that we set up a network throughout Australia, and we meet every month. It's a multidisciplinary meeting online. We have international experts from the US, and now we've been joined by Malaysian hospitals as well. So we're developing really a local expert panel where we discuss patients to try and really standardize our management of how we approach our management of these children. And fortuitously, Australian Genomics came along and saw fit to support us as a flagship, which has really elevated our understanding and support of our children and our families. We established a registry, and this is really important because that meant we can really understand our disease a lot more. We can interrelate with the international registries that exist. We established peer support platforms for our patients. So and at this point, I'd really like to acknowledge Lung Foundation Australia as well, because they really helped us in getting our community involved, and by the establishment of the Young Lungs program and the Young Lungs parents group as well, who've been instrumental. So if you're out there, you know who you are, and you know that we've done this together. It's been my absolute pleasure and honor to work and co-design many aspects of the work that we've done in developing educational resources. We put in our first lay summit last month, where we brought families together to talk about the challenges of having someone with a rare disease. And in regard to the genetic diagnoses, what we found is that we've been able to make diagnoses we would not have made through the use of the Australian Genomics technology and expertise. And I'm reminded of one particular story which really sticks in my mind, because this is a very difficult area to work in. It's very difficult to get competitive funding in this rare disease area. But there was a child who had an unusual presentation in Queensland, and we were involved and ultimately made a genetic diagnosis. And while we were talking, one of the doctors in Perth, suddenly a light bulb went on. I think he suddenly realized that actually one of his patients who didn't have a diagnosis was very similar, and perhaps that they can apply the genomic technology to make a diagnosis in the child, and made a diagnosis. And really important for this child and the family was that there is a treatment, and it has completely changed this child's life. So through the development and the opportunity of really developing a community of practice, of knowledge, of local expertise, we've been able to make a difference to the community and the families. We've hoped that we have addressed many of the concerns, and we continue to work very closely with our families, our consumers, our patients out there. So really it's an opportunity for me to thank Australian Genomics, because we would not have been able to achieve and brought differences to individual families, but also to all the families out there who have helped me elevate what we do. And I look forward to very much working together as we make a big difference to the children we've got after. So thank you.
Thank you, Adam. All right, now I'd like to move to something completely different. MJ, would you like to turn your camera on? Excellent. So Dr. Marie-Jo Brion is based at QMR Berghofer in Brisbane. Now, MJ manages the Australian Genomics data program, which is looking at the best ways to store, collect and share and use the medical information and the genomic data from Australian Genomics flagship studies. MJ.
Thanks, Tiff. So I started my journey about 15 years ago as a public health researcher, and have followed my passion for health data into this role as the manager of the data program for Australian Genomics. Our work really comes in towards the later stages of the patient's testing journey, after the clinical test has been done and the results have been produced in a report. Our program comes in to really collect all of that large-scale genomic data. It's enormous, 6 billion data points per participant, the size to max out your average laptop, with lots of complexities, and bring it together and package it and get all of the systems around so that we can make it available for use and data sharing. And our main goal with that is 3 key reasons. First and foremost, we've just heard that standard of care results in about 10% diagnostic rate. And the genomic testing has really improved that significantly. And we're seeing, you know, around 50% diagnosis. But of course, that means there's a huge number of undiagnosed patients that remain. So first and foremost, our goal is to get the data for these participants in the hands of the appropriate clinical researchers that might be able to reanalyze and find new clues and new answers for a better chance of getting a diagnosis for those that remain undiagnosed. A big reason as well for that 50% undiagnosed is that what we know of genomics is just the tip of the iceberg. We've come so far, but really there is so much more to decode about genomic contributions to people's conditions. And one of the ways we're dealing with that is, you know, each of our clinical studies, we are working to bring together all of the data for each condition so that condition-specific research can be done to improve understanding of each of those conditions and really find the discoveries that might help drive more diagnoses and inform clinical care better for all of our participants and individuals that have similar conditions. And the last reason for our drive for data sharing is 90% of our participants have very generously agreed to make their data available for broad research purposes. And this is an amazing thing. Data is so valuable and can have such a major impact on medical discoveries. And with the right infrastructure behind it, we can share this data to the right researchers for a whole range of medical discoveries. And we hope one day this will really far exceed our current understanding of all the conditions that can possibly be impacted. We have a number of challenges around this, and first and foremost, our goal is to balance all of this valuable data sharing with keeping the data safe. That is our number one priority. And we work hard around data security, privacy, there's legal aspects, making sure researchers are accountable, ethics are all in place. And there's a lot of work we do to ensure basically the right people only get the right data they're supposed to get for the right purpose. And that is a key driver of our program. We've been really pleased to release a lot of data sharing tools this year. Sharing It we just heard about, which, you know, supports the sharing of classifications of variants among the diagnostic labs. We also released a tool called Variant Atlas this year, which has been accessed by many clinical geneticists and researchers that provides them with summary information that can really help research and improve understanding. And we've got some clinical data tools which help machine readable scanning of clinical data queries. One of the things we always have an eye on is really pushing that bar and keeping it always progressing. And a lot of our activities at a national level and an international level are really looking at what's next. How do we do an even better job of this? And there are some amazing new technologies that our teams are involved in collaborating with at the international level that will support cool things like data streaming, so that entire data sets, when they're not needed, don't need to be passed over, and you can stream little portions of your genomic data when researchers just need to see a tiny sliver. Also, we're involved in developing tools where you can encrypt data and jumble it up and build tools where you can still analyze the data even when it's jumbled, so it stays in its most secure format as possible. So lots of exciting things that we have been involved in to date and are coming up in the future, and we look forward to updating everyone about it.
Thanks, MJ. That's terrific. And I love how excited you really are about this stuff. I share the excitement. I'm there too. I think it's cool. Thanks very much. What a great introduction. Sean, I might come to you now. Hello.
Hi.
Sean Murray is the CEO of the Mito Foundation and a founding director of the Childhood Dementia Initiative. So in his role, Sean drives the work of the Mito Foundation in supporting the Mito community and ultimately finding a cure for Mito. Sean.
Hi there, Tiff. Thanks for having me on today. As you said, Tiff, my day job is with the MITO Foundation. MITO is short for mitochondrial disease, which is a collection of genetic disorders. At current state, I'm advised that there are over 300 known genetic causes of mitochondrial disease. So in a way, it's almost like a nice little a mini set of genetic diseases, and the complicating factor, because it always gets complicating with mitochondrial disease, is that we have a different type of DNA, not just our regular DNA, but we have the other type that is often forgotten, that's called mitochondrial DNA. And we can have problems in our mitochondrial DNA as well as our regular nuclear DNA that can cause mitochondrial disease. So the MITO Foundation was very keen to partner with Australian Genomics when the opportunity arose at the start of this initiative. One of the objectives that we had in partnering with Australian Genomics was to increase the rates of diagnosis of the Australian mitochondrial disease community. We've heard a couple of times already about standard practice resulting in about a 10% diagnosis rate. That's the kinds of numbers that we're hearing from our clinicians. Epidemiology would suggest that the rate of diagnosis of mitochondrial disease is pretty ordinary, and awareness of considering investigating for mitochondrial disease is part of that. A lack of knowledge of the genetic causes of mitochondrial disease is another complicating factor there. The 300 known genetic causes, that rate of knowledge has increased significantly over the past 10 or so years, and the Australian Genomics Initiative has certainly boosted that knowledge base of the kinds of causes of mitochondrial disease. So that's been quite phenomenal. My role with Australian Genomics, beyond just being a partner through the MITO Foundation, is I'm a member of the Community Advisory Group, and that is led by Richard Vines from Rare Cancers Australia, and it's comprised of representatives who have personal lived experience with genetic diseases and disorders, and others who are representing patient advocacy groups for a various genetic disorder. And I think my observation through the process really is one of a genuine willingness and aptitude to consider all of this work that's being done, and the bulk of it, as we saw from that animation, the patient's experience can often be identification of an issue, sent off for testing, and then, like a swan swimming on a lake, a test result comes back, and then it's explained and away we go. But then behind the scenes or under the surface of the water, the legs are kicking madly and the machine kicks into gear. So, and the breadth and the depth of everything that's gone on, and we've heard already from MJ and from Stephanie as well, the kinds of things that happen really that largely the patient won't be aware of, and arguably shouldn't be aware of, is quite phenomenal. But through the Community Advisory Group, we've had a great opportunity to inform, to hear about, and to provide suggestion and advice for considerations from a patient's perspective at pretty much all of those steps. And I think that's a standout to me about what's happened in the past 5 years, is this genuine patient centricity to all of that work that's gone on, because I think sometimes there is a risk of being lost in esoteric ventures in academia, etc. But certainly that's not what's been the case here, and certainly my personal experience in my involvement with the Australian Genomics Group. So I think that's a real plus there. I think some of the other big wins around Australian Genomics. I've got a couple more minutes, Tiff. You can hang around if you want. You were sensing a wind up. I think we talked about this access to diagnostics and just a pathway, a known pathway, equity and access prior to Australian Genomics, depending on where you lived and who you happened to come into contact with, really influenced your availability to your access to genomic testing to seek a diagnosis. And so I think that that's been a real a real win is having that standardized approach and equitable approach. And it also presents a challenge then. This is something that can't just stop if Australian Genomics stops, or as Australian Genomics moves into its next phase. It's really important to maintain that, and beyond, you know, rare diseases or one type of rare disease, but as and when it's appropriate more broadly. I think the other couple of things I wanted to mention around Australia, the past 5 years, or even, you know, what are the challenges now that go beyond, is I think we can't take for granted this 90% of participants who agree to share their data. I think that's a testament to it, I believe, and what I've seen in the patient communities, a genuine willingness or altruism to give up their data for the benefit of the next group of people. And I think that it is important that cannot and should never be taken for granted, that everything it needs to be done to maintain that trust and to deliver results to that. And I think then the challenge is maintaining that patient centricity to everything that's being done through Australian Genomics. And track record's great so far, so we've just got to maintain the rage.
Thanks so much, Sean. The involvement and working with the community advisory group over the last few years has been such an amazingly enriching and humbling experience from my personal perspective. And, you know, Kathryn teases me that, you know, she says, you love them. And I genuinely love the meetings. I love the engagement. And I'm, you know, so delighted that, you know, the members are going to continue to work with us moving forward. Thanks, Sean.
Pleasure.
All right, last but certainly not least, Jodie. Hello.
Hello, hi.
So Associate Professor Jodie Ingles is the head of the Cardiogenomics program at the Centenary Institute. She's a cardiac genetic counsellor with extensive experience working with families with inherited cardiac disease, and is involved in and leads a number of preeminent heart disease research programs. Jodie.
Thanks, Tiff, and you know, thanks to Australian Genomics for the invitation to join for this panel session and being able to talk to, you know, all of the amazing participants and clinicians and lots of people that have been involved in Australian Genomics so far. And I'm certainly really, you know, I think my experience so far has been really great. So I'm happy to share some of that with you. So as you've heard, I'm a cardiac genetic counsellor, but I'm also an associate professor at the Faculty of Medicine and Health at the University of Sydney, and I lead a research program, the Cardiogenomics program at the Centenary Institute. And this research program really is focused on understanding how we can best use genomics to better care for families with inherited heart diseases. So my role as a cardiac genetic counsellor began in about 2003. So I've been doing this for about 17 years, and I've been seeing families with inherited cardiomyopathies and inherited arrhythmia syndromes, and also families who present to us because of a young sudden cardiac death. So this might be, for example, a 15-year-old who dies suddenly playing sport at school, or a 30-year-old who has a cardiac arrest and dies suddenly while at work. And often these people are fit, healthy members of the family and the community who don't actually have any pre-existing heart problems. So you know, causes lots of obviously grief, but issues around what the actual cause of that disease was. So in that time, working in these clinics at the Royal Prince Alfred Hospital, I've actually witnessed the crazy evolution of genetic testing. And, you know, back in the day, we really could offer barely anything. I mean, research testing that was done overseas that might take 2 years to look at a couple of genes, to now routinely offering whole genome sequencing to lots of our families. And I guess, you know, being involved in Australian Genomics, mostly my involvement has been through the cardiovascular diseases flagship, and we're one of the more recent flagships. And so we're still midway through recruitment of about 600 individuals with an inherited heart disease all around Australia who undergo whole genome sequencing and participate in lots of different research studies. And, you know, I guess I feel really fortunate because my involvement in this has been as a researcher, but also on the front line as a cardiac genetic counsellor, and being there and explaining these studies to the participants. And I, you know, I think the one thing I'm always really amazed about, and this is something that others have touched on, and especially Sean, is that the willingness of these individuals to be involved and to give their time, and, you know, to really feel motivated and you know, supportive of this research. And often at times when they've got really significant medical and health conditions going on in their families. So I think that that's just something that I always find really inspiring. And, you know, if you're a participant on this call, I think, you know, from people like me, we definitely cannot underestimate how much that helps us move our whole field forward. So it's really incredible. One of the highlights so far for me with Australian Genomics, and this is something that you know, MJ gets excited about data, but one of the things I get really excited about is being able to lead the multidisciplinary team meetings that we hold almost weekly. And this is where we discuss the genetic findings that come up from whole genome sequencing in our families. And these are calls that have, you know, lots of our flagship members joining, lots and lots and lots of expertise from different people, and not the sort of people that we would have been able to get on a call on a regular basis ordinarily without having Australian Genomics to help pull that together. But I think the thing that we do see on a pretty regular basis is that genetic testing and being able to offer genetic testing as a frontline test using whole genome sequencing, which is not the norm of necessarily how things are done around the world, you know, we're actually able to make really important findings and diagnoses for families in similar ways as we've heard already on this call. So being able to look at genes that we might not have thought would be causing heart diseases, but also finding changes in genes that we might not have been able to find using more traditional genetic testing approaches. And the most exciting thing is when we find a really interesting change that we think has a really important implication for a family, you know, suddenly you have this huge network of really passionate and knowledgeable researchers and clinicians from all around Australia on these calls who are really motivated to try and, you know, bring all of this together so that we can get a result for the family. And for me, that's probably been the most exciting thing with Australian Genomics. I think before this call, reflecting on, I guess, the challenges, I think there is one important pitfall that I do think does need to be mentioned, I think has been mentioned already, and that is that, you know, we do only understand the tip of the iceberg with genomics and how genes can cause disease, and you know, that can be a challenge because there's so much uncertainty in what we're looking at and what we're trying to interpret. But also as a researcher, I think that that's an incredible opportunity to understand more and know that our discoveries will impact on other families, you know, whether they be in Australia or elsewhere around the world. So, you know, I think the important thing is, you know, I think I'm one of the fortunate people that kind of is able to wear two hats. So on one hand, I'm a researcher and I can get really excited about the discovery potential of looking at some of these findings and, you know, really sort of big picture, you know, maybe this is a cause, but at the same time, I can also very quickly put on my genetic counsellor or my clinical hat and think, okay, well, this is definitely not ready to be fed back to a family. There's so much uncertainty and we really need to do a lot more work before we can say with any certainty that that's actually the cause of disease. So I'm a really strong advocate for the need for genetic testing to be offered, I guess, hand in hand with research. And, you know, there's so much that we're doing that we're learning at the same time. And I think Australian Genomics really allows that kind of, you know, side-by-side approach to genetic testing with really strong research focus at the same time. And I think that, you know, I really hope going forward that we're able to continue that model of cardiac genetic testing into the future. So I'm really excited. I think as of next year, we'll start to get more data from the cardiovascular diseases flagship, and I'm really excited to see, you know, how we've been able to impact on families, and I'm hopeful that it's in a really positive way, because that's certainly my anecdotal, almost weekly experience so far.
Excellent. Thank you, Jodie. Well, that's been a terrific insight into the different panelists' perspective. I invite all of you to turn your cameras on now. Here we come to the fun part, the Q&A. And participants, please, we've had a few questions coming through on the Q&A chat, and a lot of people, thank you to all of those on registering for this event who submitted questions at that time. So I think we might kick off with you, Kathryn, and this is there's sort of two aspects to this question. We've had a couple of questions of a similar theme. So how has the contribution of Australian participants contributed to international research? And then the flip side of that is, how have our Australian participants benefited from research that's happening globally?
Well, it's certainly definitely a two-way street, and the reason for that is we're very linked in with the major international efforts in genomics, with a focus on the responsible sharing of clinical and genomic data. So many of us work very closely within what's called the Global Alliance for Genomics and Health, which is a partnership of over 100 countries around the world. And the focus is, how do we develop the standards, both from a regulatory and ethics perspective, but also the standards for speaking the same language when we're talking about genomic and clinical information, but also the technical standards in how you share that information. So I talked about Sharient as a local way of sharing information about individual patient changes in their genome that might help others. That certainly has really improved that our diagnostic ability. But it's not just within Australia, we're sort of plugged in internationally as well. So if you think about it, what it means is that when a genomic test is done, and with a patient's consent, we can share an information to say, we now know that this particular spelling mistake in a gene is associated with, just following on from Jodie, a specific form of inherited cardiac disorder. We not only share that specific piece of information with labs around Australia, but we're also sharing it internationally. And that means when that turns up again in another patient, through all of that information being linked, we immediately have a flag with all the evidence behind it to say, yes, this is likely the cause of the disorder. So it's that interchange that develops not only our patients here in Australia, but it's that collaboration, which means any findings and discoveries we have are then benefiting other patients around the world.
Thank you. All right, Jodie, I'm going to throw to you. We have a couple of questions around when one doesn't get an answer from an initial clinical testing. And I think it's really important to acknowledge that, despite the great advances over the last few years in diagnostic genetics and genomics, many participants still don't achieve a diagnosis. So similarly, we've got a couple of questions along these themes. And so from, I guess, your genetic counselling hat, what advice do you give to people who don't get an answer from genomic sequencing? And then, sort of doffing your researcher hat, what procedure do you then follow when you're unable to identify a possible genetic defect from the first round of testing?
Yeah, it's a really good question. And I think the first thing to say, this is an example of why pre-test genetic counselling is so important. And part of that is helping families to understand what can actually be achieved using genetic testing at this point in time. And it's a field that's moving so quickly. And so, I'm always having the conversation saying we're able to do testing, but we're only able to interpret what we understand at this point in time. And that could change into the future. But there is always, some level of uncertainty in what we find. And there's also You know, we don't necessarily know all of the genes. We don't necessarily know all of the ways that these genes can be impacted that can cause these particular conditions. So we do try to make sure that people have a really good understanding of that before they go into genetic testing, because I think if you have the expectation set right, then there's less chance of you know, surprises that might not, you know, necessarily be well received by the family. From a researcher perspective, you know, if we're very confident that a particular family has a condition that is heritable, so is caused by a genetic change, and I guess that's a lot of the families that we are seeing in the Australian Genomics flagship, one of the really fun things, and fun being, you know, maybe an unusual word to use, but one of the fun things we've been able to do is to put together all of the ways that we think that, you know, could best help make a genetic diagnosis in families for our cardiovascular flagship. So we have a tier 1 of genetic testing, and that's, we've put together a list of genes that are just the ones with really, really robust association with the diseases that we're looking for. And these are the kind of the clear-cut findings that will go back to the family. If we don't find anything at that point, then they move to a tier 2 stage. And this is a much, much broader sweep of our genome, and still looking at a lot of the genes that we have some, you know, a little bit of understanding for, but in a much, much broader way. And really excitingly, through that, we've found some really interesting genetic changes. And, you know, as I'm sure you can imagine, the heart is something that's impacted by a lot of conditions. And one of the things is that sometimes those other features for different syndromes or conditions can be really subtle, and it can look like the heart, you know, problem looks to be the primary part of the disease. So we're seeing patients in our clinic who have seemingly heart problems, but it's actually part of a big, wider syndrome. And this tier 2 analysis is allowing us to identify that. And so that's one really exciting thing. Going further beyond that, if we think that we've got a family where even on the tier 2 analysis, we can't find anything, but there's, you know, for example, other family members who have the same inherited disease, we can do even more comprehensive approaches and do, you know, genome sequencing in other individuals as well. And that's sort of really getting into that gene discovery phase. So Australian Genomics is amazing because we can kind of cover through all of those different points and hopefully give back answers to the families.
Excellent, thank you. I like the note of hope too, and when you're finishing off there, that's terrific. Adam, we've had a question come through that you might like to speak to. Do you see drug discovery and development now being centred around disease-causing genetic variants?
Oh, great question. This idea of precision medicine and personalised medicine is very much the next wave in the future of the way we practice medicine. You know, let's take cystic fibrosis as a perfect example. We have this is a disease that children used to die by 5 years of age in the 1950s, and we're anticipating now that babies born today will live to ripe old age and die of old age inconvenienced by taking a couple of tablets a day. And that really is the hope that we give to our babies that who are newly diagnosed now. And why is this? Well, obviously we've learned a lot about the gene. The gene was discovered in 1989. And just in the last few years, there have been new drugs that are specifically targeted to the genes and the genetic variants of the cystic fibrosis gene. That are specifically available for those genes. It's been an extraordinary time in cystic fibrosis. I've seen amazing stuff. I've seen lung function go from 35% to 50% in 4 days. You know, parents saying their children stop coughing, and these are sick children with getting compassionate access. The key is better value healthcare. The key is we understand that not everyone with the same variant responds the same way, and this is a bit of the challenge where the precision medicine bit comes in, and that's why certainly in Sydney Children's Hospital and around the world we're developing this technology where we're creating children avatars. We have Johnny and Jilly in a test tube. We take bits of rectal tissue, which I'm assured, Tef, doesn't hurt. So if there are any volunteers, we need some controls, let me know. We take nasal cells, we grow them in the laboratory, and many of them live forever. And we can test these cells against these new drugs, these modulators that target the genetic cause of the disease. And our cells swell up, and if they swell, that indicates that these children will respond. So our challenge to the regulatory authorities is to take this new way of looking at drug response to variants, to take to our regulatory authorities and say, look, this is a new world. We really have to have a process that's fit for purpose in moving forward in precision medicine in Australia. We lead in the way, and it's a very exciting time. Now, CF is just an example of using variants. So the same approaches in cancer, the same approach to neuromuscular problems. So it really is, we all have the same approach, and it's really important that we collaborate, that we're not diseased in silos. Kathryn put up that picture of silos. Certainly we have our diseases that we're all passionate and care passionately about, but by working together, and this is where the excitement of Australian Genomics has really catalyzed this environment. So I'm really hopeful, and I think when I meet my families with a new diagnosis of cystic fibrosis, this is a completely new era, and they must not Google.
Thanks, Adam. All right, we've had a question now around multidisciplinary teams, and perhaps Stephanie, I'll start with you, and then we'll see if Kathryn also would like to comment. The multidisciplinary team seems to be a crucial part for the successful execution of a genomics program. Is the facilitation of this collaborative structure something that Australian Genomics is promoting within healthcare networks, or is it something that needs to occur more organically? So, Stephanie, from your perspective on sort of health services research and implementation science, is this something that we need to strategically construct, or is it more an organic process?
Thank you, Tiff, and thank you for that question. I find the whole concept of the multidisciplinary teams within the field of genomics fascinating. You're bringing together groups of different experts who have to come together and they have to learn from each other. So they're no longer the overall experts. They have to come and they have to be able to share and discuss the relevant findings from their different aspects of looking at genomics. Yes, I think it is something that needs to be supported. I think it is something that needs to be actively supported through something like Australian Genomics. I think that it's quite hard for a lot of the different professionals to necessarily free up that time to come together, because it does take, and Jodie and Adam will be able to say, it takes a lot of time each week to come together to be discussing all the different cases that they are. So I think that by having a group like Australian Genomics that supports that kind of activity, it demonstrates the importance and significance of the work that they're doing. And from what I've observed from the multidisciplinary teams, and I've already fessed up that I am no genetics or genomics expert, they seem to be just so central to actually moving forward, not just the diagnosis for the individual person they're discussing, but for the whole field. I find the meetings just fascinating to watch. What I would also say about the multidisciplinary teams is that they do evolve over time. So I think that support to help set the sessions up is really, really important, but I think they're not going to be static entities. And I think that as each of the different clinical fields evolves and matures in not only the relationships, but in the knowledge that they're gaining, then I think that we'll see those multidisciplinary team meetings shifting, and the people that we might want to come into them might start to vary, and some people might sort of be able to sort of take a backward step, and I think we need to view that positively. And I think, like a lot of genomics is moving, and as Jodie was saying, you know, sort of the pace of change sort of within cardiac genetics and genomics is moving so fast. The same thing is going to happen within these kinds of organisational sort of structures.
And just Tiff, to add to Steph's comments, I think I think it doesn't, well, it could happen organically, but I think the most efficient and effective way is for it to be facilitated. And so those multidisciplinary teams actually become learning and educational environments, so that I think of the holy trinity of the clinician, the bioinformatician who does the data processing, and the laboratory scientist. You know, it sounds like the beginning of a joke. I've walked into a bar, but in actual fact, when you bring them together in a multidisciplinary team, they all start to learn each other's language, and it's a continual educational process. The thing is that the clinicians we find also is genetics and genomics is no longer just about, you know, the clinical geneticist and the genetics counsellor. You know, Adam is a case in point as a respiratory physician who's embraced genomics, and we have neurologists, we have cardiothoracic surgeons even, and cardiologists. So it's something that's going to touch on every medical specialty. And ensuring, I think one of our big goals and continuing to the future is that we have genomics literate physicians and specialists, but then also we need genomics literate general practitioners, because if you're talking about something like screening parents to see if they're carrying a genetic risk to their offspring, then you're going to be dealing with your GPs. So that's part of the vision into the future, is how we make sure that we engage and educate as we work.
Thank you. MJ, we had a question submitted at registration, which is talking about what are the opportunities for creating tissue banks and data banks for research now and as future technologies develop. Would you like to comment on opportunities for not only sort of biobanks, but data banks in Australia, and facilitating how they might talk to each other to benefit patients?
Yeah, absolutely. So, you know, one of the things I think that we have been striving to do in this program, but also in moving forward future activities, is centralizing as much data as possible securely. So, you know, one of the amazing things that Australian Genomics has achieved is the extent to which data has been brought in from so many different places around Australia, every state and territory, 32 different sites, and bringing that together into a database. The next layer of that is really enabling that data set to be queryable, to pull out, you know, in as much as possible, you know, a national data set, so that similar patients can be drawn together to be analysed, not just within this program, but everywhere around Australia. If we can identify rare disease participants or participants with the same cancer types and bring them together and analyse as a medical cohort that wasn't from the outset recruited to participate in a study, but at the end of the day can be brought together as a cohort, then you can draw together similarities, you can do your research, you can match patients with rare disease, and that's really, you know, I think something that is the vision and the dream for the future. If we can move forward in Australia as having that centralised infrastructure, which is very challenging in Australia. You know, our health care system is state by state, it is managed by the state, and in the future, if we can centralise our health data in that way, then that's sort of the ultimate biobank for Australia that hopefully can produce the discoveries that would have the impact on patient diagnosis and clinical care.
Thanks, MJ. Keeping with that theme around sort of the Federation of States, Kathryn, how do we ensure a uniform approach to equitable access of genomic testing across the state and territory and federal sort of jurisdictions?
So I think there's, you know, it's a multi-pronged approach to this, because first of all, as you sort of saw from our representation around the country, we do now have this very smooth network of clinicians and laboratories around the country that are interconnected and meet on at least a monthly basis. And I must give a shout out to the Australian Genomics team, who I think organise at least 1,000 meetings every year of bringing all of these people together. So there's that interconnectedness and that sharing of knowledge, and where there's an expertise in a specific laboratory or specific state, then that's ensuring that, you know, if you happen to come in New South Wales, but the expert's in Perth, that the analysis and the testing is being done by the experts. So that's the first thing. The next layer is, as MJ mentioned, is that we have a federated system. So we have our state government-based hospital systems and genetic services. And then we have the federal government, which is actually supporting a lot of the testing as well. So it's how do we align both of those things and make sure that they're complementary and that they're leveraging off each other. And that interface, I think, is also what Australian Genomics has been doing. So, and by demonstrating the value to patients, then both state and federal governments have been very supportive of those efforts. But then that equitability and making sure that we're also paying attention in terms of rural areas and remote areas, that is a challenge, although it's not just a challenge for genomics. I think it's a challenge for all specialist care. But as we widen our network and we're including doctors that may, or clinicians that may travel out there, but you know, in COVID, we've all turned to telehealth, so we're learning new ways to do things. That's the way to ensure the equity of access. Finally, I talked about the MSAC application, and that testing for kids with childhood syndromes and intellectual disability is now covered by Medicare. So that's the ultimate equity of access if we have a universal funding approach. And we are very lucky with our health system that we have this nationalised system.
Thank you. Sean, we had a question submitted at registration that specifically pertains to discoveries in mito, but we might also hear from Steph because she did allude to that sort of the amount of time it takes to get from foundational discovery to implementation. The question was, how long is the process from discovery of a new strain of mito disease to information being published in journals?
Wow, that's a great question. I don't know that I have the answer. I would argue that it's fairly swift to get into publications, noting the standard lag that frustratingly happens there.
Unless there's COVID in the title.
Yeah, right. I think that it probably does, you know, I would imagine, and Stephanie, please jump in here, it'd be in the order of months from discovery to publication. But what's probably, it does underscore the importance of things like sharing and like centralized databases so that others can interrogate that around Australia and around the world for that new piece of knowledge. And it, you know, an anecdote or a story around that is there was a patient, a family who lost their child devastatingly within the first few days of life. I'm going to say about 5 or so years ago, and no known genetic diagnosis, but the analysis went on, and then the reanalysis and the functional genomic studies and all the work that happens once an undetermined genetic diagnosis or a lack of genetic diagnosis came up. And then finally, that identification was made, and it was verified in a couple of other places, and it was published. And then another family had a very similar situation where they lost their child, but their diagnostic turnaround was in the order of weeks. And devastating position for them, having lost their child again. However, what it gave them was confidence around what the implications were for them having a family and continuing a family, because they knew that that particular genetic condition was sporadic and just random in nature and not inherited. So it meant that for them, you know, they could have confidence that the likelihood of them having another child with that syndrome would be minuscule. So, you know, you can't underscore the importance of that cycle of knowledge and the rapidity of it.
Yeah, I think Sean's quite right. I think that getting the actual technical discovery into publication is a relatively short journey in comparison to the implementation and the change in practice that happens as a result of a particular finding. So they're the bits that we don't tend to find in the literature as much as maybe the specific gene discoveries that are found. So obviously that's my area of interest in saying, well, that's fantastic that you found that gene, but how has it changed practice? How has it impacted on families? How have clinicians accessed this information? That kind of thing.
Mm. Excellent. All right, we've had a question about data standards, MJ. So the question is, how successful is the linking of patients' clinical data to the genomics data, given that states and hospitals use different systems and e-health records are yet to be working effectively? Hashtag opinions are their own.
No, that is a great question. You know, the clinical data in the context of genomics is obviously so critical because the clinical data is what's needed to interpret the genomic information. Without all of that accompanying medical information, and you know, there's 100 different terminologies for the same condition by different doctors, free text with typos, and systems that don't talk to each other, as mentioned in the question. We in our data program deal with standards where the data gets formatted in a way that is interoperable with healthcare systems. It is called the International Fire Standard, and embedded in it is use of what we call ontologies. So instead of fluid use of any clinical terminology that people might want, it is locked into terms that are coded. And the amazing thing about that is once it is coded and in that machine readable format, you actually have the power to bring it together and do analysis in a way you know, that a human manually would really struggle to do. So we're really working together to implement that in our program and to develop the tools that can really bring together the clinical data from healthcare. At the moment, you know, within our system, that is done by manually taking out the clinical information and putting it into our database. Obviously, in the future, for this to be scalable across Australia, we want systems where that is happening from the outset. And one of the things we are doing is working with diagnostic labs to have that information encoded in that machine readable way from the very beginning and bypass all of that. So there are various processes that are in place that can overcome those challenges of the current systems not talking to each other, because that is an enormous problem that obviously won't get solved in the next couple of years. And once you have that sort of embedded in your database, then you can go international, and there are groups that have data stored in that international format, and then that capability to branch out and connect data sets securely in a machine readable way with groups all around the world then becomes a possibility. So that's part of our work.
Mm. Excellent. A lot of work still to be done though around standards. Mm. So we've had a lovely aspirational question around where will genomic testing be in 2030 and 2050? Now this is one I'd like everyone to try and tackle. So not in 25 words or less, but you know, we've sort of got another sort of 10 minutes of this this program, this section of the program. So Jodie, would you like to kick off?
Sure. I'm actually curious to know where genomic testing will be in 12 months' time. I mean, that's actually how fast things are moving. And I think if we are going to look further into the future, though, I think the way that the research is moving is that in terms of being able to understand the sequencing data that we're looking at, I think we're going to end up with the ability to not only understand rare genetic changes, so that's one change causing disease, but we're also going to start to understand how, you know, lots of small changes that might be more common can contribute to other diseases. So even chronic diseases like atrial fibrillation and cardiovascular disease that occur more commonly in the population. But I think on top of that, we also need to understand how lifestyle and environmental changes also impact on our risk of developing disease. And I think part of this all comes back to, you know, when we see a family at the moment in clinic, and I know this isn't just in the cardiac clinic, but we can have one person in the family who has a particular condition. We can do genetic testing and find that there's other relatives also that are at risk. We don't know how severe their disease will be. We don't know if they'll even develop disease or what their needs might be. So I hope that in future that we can use genetic testing in combination with much, much more data to actually better predict what those impacts might be.
Excellent. Adam, what are your thoughts on this one?
Yeah, no, good question. So look, I helped write the Australian Asthma Handbook, and I confess it's completely wrong. Completely wrong. Because it takes a stepwise approach to treatment. So if you step one, try this, if this doesn't work, step two. What I want as a physician is to be able to sit in my room with my patient in front of me and say, we're going to start you on a medicine, and actually know, presumably by having their genetics on my screen, to say this is the medicine for you, not as I do now. Step one says try this puffer, come back in 6 weeks time, we'll try a different puffer. I want to take population data and be able to apply it to the person sitting in front of me as a physician. I mean, they may not even need me, they may just need a machine and that will dispense the right medication. Hopefully they still will do, but that's what I really want. That's why I want to see genetics come to the clinic and help guide my treatment and not making a guessing game, which it currently is in some aspects of medicine. Don't tell Asthma Australia, please.
Who are hopefully not online. Sean, what are your thoughts in this space?
I think, Jodie, you touched on it. This is such a fast-moving field. You know, where will it be in 12 months, let alone in 10 or 30 years. But I think what we can't deny is that this is a tsunami, and it's coming. And if it's not coming, it's here. And it is or will be ubiquitous. I think we need to be mindful of, say, a potential paternalistic approach to, there's only a few of us who understand this, so let us sort it out for you, or we have to be involved in every decision, because that bottleneck will explode very quickly. I think, Kathryn, you touched on that, you know, GPs will be the front line, and it's going to come sooner rather than later. So I think anything that we can be doing now to enable that and be ideally in front of that wave would be important. And, you know, that's probably before 2030, let alone 2050. That'll be Star Trek, just that sort of stuff.
Excellent, thank you. MJ, what are your thoughts? And we see, and also another comment around sort of data science and machine learning advanced algorithms. Do you think that's going to be involved in the direction for genomics 2030, 2050?
Yeah, for sure. I mean, you know, with the so-called tsunami of data, we know that, for example, although all of the data that's coming out genomic research to date has typically come from research studies, we know that, you know, within about 5 to 10 years, the majority of the genomic data is going to come from the healthcare sector. Something like 60 million genomes is expected to exist by that time, which is just phenomenal. And that's not even considering the associated clinical data, kind of as previously mentioned, from all the different systems. So when you put all of that together, probably not all in the one spot, you know, the tools and the compute power, the algorithms, the technology, the data standards that's going to be needed is quite mind-blowing, and the security all around that. And, you know, I struggle to even get my head around kind of the possibilities that are there. But going back to the original question, I think also in terms of the genomic testing itself, I sort of think perhaps we'll end up with almost a divide in the genomic testing, as in there will be all of the data that come from the clinical space with the drive around diagnosis and clinical care. But we also know in the general population, people are very interested in genomic information of their own. There's about 15 million people in the 23andMe database that have commercially purchased a genomic test. I was one of those curious people 7 years ago. And the information, you know, that is available is pretty scarce in terms of what we can tell people about predictions of their health and their current health traits. In terms of those common traits people are quite interested in. 23andMe did at that time release health reports. I read through all sorts of interesting things. I was more likely to drink more coffee than your average person, etc. But all of those traits, all of those reports have now been removed because the scientific evidence behind it is not good enough. So I think as research evolves over the next 30 years, as data comes together, as we do the research, that evidence for all these different traits and risk factors and capabilities to determine your health across the life course, that'll increase. And I think, you know, your average person will only be more and more interested in how that affects them, whether it's the clinical setting or not. So I think we'll see two spaces and two pieces of work and two requirements to engage and progress with the right tools and communication platforms for that.
Mm. And certainly, you know, as reference databases become better enriched with underrepresented populations, and, you know, the work of the Centre for Population Genomics that's establishing in Australia will be very important there. So yeah, thanks, MJ. Steph, what are your thoughts looking forward?
Gosh, 2030 and 2050. 2030 doesn't feel that far away, really, does it?
It doesn't.
Sadly. Well, kind of in my ideal world, I'd like to see wider access to genomic testing. I'd like to see that there would be secure funding that goes with genomic testing, that we have got the evidence behind, you know, sort of those particular clinical sort of areas. And I think I'm just thinking about the lessons that we can learn from COVID, and just thinking about that whole wider access sort of situation, thinking about how we can use some of that, for example, telehealth stuff that we've done, to be broadening our access out to rural and remote communities more, so that we can have not, you know, sort of one specialist and you have to wait to see them, or wait till they fly in to see you, and that sort of thing. So I'd like to see that kind of thing coming in more and more, whether that's 2030, well, that could be 2030, couldn't it? I think Sean and I think Adam mentioned something about primary care, and GPs are going to be sort of, you know, part of that front line of that tsunami that's going to sort of come their way. Whether I'd like to see genomic literacy raising in our non-genetic medical specialists. I suspect that the next step would be the primary care clinicians. I think we've still got a little bit of a journey to go before you know, sort of it's full bore for all primary care physicians. But I mean, it's coming. It's coming. There's no doubt. So.
I think you're absolutely right with the primary care piece, and empowering and educating non-genetic professionals is, yeah, absolutely critical to the way forward.
And I think you're so right, Tiff, around that whole sort of empowering side, because the education is absolutely essential. We know that, but that on its own isn't going to be the thing that's going to be the turning point for non-genetic medical specialists to feel, once it's available to them, that they can offer. So it's going to be a combination of upping the education, obviously, but also sort of being able to empower people so that they can engage.
Excellent. Kathryn, I'm very interested in hearing your vision for genomics in 2030 and 2050, because it's probably also what I'm going to be busy working on moving forward.
I just thought two broad things, because I agree with what's been said around the Zoom, but I do see that, you know, currently we do newborn screening. So when a baby is born, there's a heel prick test, and that's screened for 25 disorders that where it's important to know about them early, to be able to intervene, to prevent you know, the complications or manifestations of the disease. and that is done sort of universally around the country. I do predict, whether it's 10 years or so, but it relates to the costs of sequencing coming down, but our knowledge also improving, is that newborn screening test will be a genomic test. And what is the good thing about a genomic test is that throughout our lives, our baseline genome that's in our cells it remains the same. It's stable. It can change in things like cancer, but when you talk about our genetic makeup, that is something that is stable. So what we end up having is that sort of resource that you can dip into at different points in your life to get the information you need to inform whether you're at risk of something or where a treatment might need to be tailored to you. So I think that's where we will get to, is that we'll have that as part of our medical record in newborn screening. Like in Mackenzie's mission, we're screening for over 1,300 genes compared to the 3 that are usually done in reproductive carrier screening. And I think that will evolve so that we're interrogating what is useful to know about in newborns, where we can put interventions in place that are going to benefit that individual. But, then it's, as Adam mentioned, you want the right drug first time for your patient, and you want to avoid adverse events or bad reactions, which can be genetically based. So before you prescribe something, you will also you'll be able to interrogate that genetic information on your patient. And I do think that interaction will become more, plain English, that you'll have that as part of the medical the patient's record, and you can type in and go, I want to prescribe this drug, and it will sort of go and zip back at you that no, that would cause an adverse reaction, and in this patient's particular makeup, this would be a better drug to target a specific output. So it's really that extreme of personalisation. And I think the other thing I think will happen that we're striving towards, which sort of goes in the that I came before it spits out a result, is that we will have Google Genome. So on our phones, if we are, if we're working as clinicians or as researchers, we'll be able to go into Google, pop in a gene, and it will ping all of our interconnected collaborative networks around the world and actually give you an immediate feedback on what is known about that gene or what is known about a specific spelling mistake. And it will take the guesswork out of what we do, because we're working together to build that knowledge base that we're all putting in our knowledge, but we all then have the ability to take that knowledge back out again.
I just had the image of Google Stocks just climbing the idea of Google Genome. Alphabet's already patented trademarked the term. All right, look, at this point, I'd like to thank all our panellists for that interesting discussion. Kathryn, I'd like to invite you to close with sort of an update on what's happening with Australian Genomics and what are the next steps.
Sure thing, Tiff. Here's some slides I prepared earlier. Well, I think this has been a wonderful session and a great enthusiasts on our panel. And it's now what is next for Australian Genomics after this first 5 years. And I'm very happy that we have sort of inculcated ourselves into the genetic services and research around Australia. And I think very much at many levels are seen as an organisation that is really boosting and accelerating how we're approaching genomics around the country. And currently we are underpinning and supporting a number of programs that are going forward. We've mentioned Mackenzie's mission a couple of times, and that is where it's initially a research project targeting 10,000 couples that are to screen them to see whether, before, usually before they're pregnant, to see if they're at risk as a couple of having a child with a genetic disorder that might have severe consequences. And, you know, currently in sort of standard practice has been screening, I think, for Down syndrome, spinal muscular atrophy, cystic fibrosis, and Fragile X as examples. Whereas this is screening for over 1,300 genes associated with 700 different disorders. So it's quite a different undertaking from what we've been talking about with rare diseases. And it's also involved that initial step of engaging with general practitioners around the country, making sure we're targeting rural areas and remote areas as well as in the city. So that equity of access approach is built into this study as well. And also is built in what else can you do with that information if the patient wants it? So, you know, can you then look at the parents that have been sequenced to look at their genetic risk and then give them back valuable information about their own health? So this is really I think a study that is taking that step and looking into the future with some of those futuristic predictions that we came up with. You know, it's actually starting to happen now. We're very involved in an ongoing way with the cardiovascular genetics program that Jodie's talked about, the Acute Care Genomics program, a leukodystrophy research program, starting to use genomics if there is a stillbirth or an early miscarriage. How do we use genomics to help work out what has gone wrong in a time when there's, you know, often no answers. So this work is continuing with this whole different range of studies. And we certainly, it's not yet confirmed, but we have been invited to apply for ongoing funding to maintain this wonderful network that we've developed and to continue to build and share all the tools and the resources and the capabilities, and to support our wonderful team of counsellors and project officers in every state and territory, so that we continue as a country to not be fragmented and siloed in different states, but that we present and we will benefit from being a single cohort of 25 million people that are really all benefiting from genomic knowledge. So that's our vision into the future. So the model that we're looking at is, this is a very complex Venn diagram in terms of where we're connecting. And so we've certainly always connected in with research with our institutes and universities and state genomics initiatives, very much again, facilitating and embedding within healthcare and making sure we're bringing all of that together to continue that very important education piece. The data networks MJ's talked about, and how we're all speaking the same language and having that interoperability around the country, but also as we're reaching out with the global genomic initiatives so that we're benefiting and contributing from the knowledge that's generated. And then the very important interactions with industry, and that's also how we then lead this information into clinical trials. And then finally, and very importantly, that interface with our state and territory and Commonwealth governments and government agencies, because the goal here is to build this as a sustainable framework that becomes, you know, part of the furniture in terms of how Australia is tackling genomics. And so just finally, you know, just some of our visions, apart from what we've talked about, is that reach and that equity of access to all Australians who can benefit, to make sure that everything we do is based on evidence, whether it comes out from collecting that sort of wide range of experience or doing the deep dives of research in terms of providing accurate answers. Upskilling our workforce, and you know, we've got every one of our 450 investigators is a genomics champion around the country, and we know that just that continued education, now that we're engaging across GPs, and really, and also engaging I think, very broadly with the general public, so that genomics is something that people understand. And when you can understand its benefits, it seems a lot less part of science fiction. Not only should the access to this be equitable, but so important with our Indigenous peoples and with our really multi-ethnic society, making sure that our approaches are inclusive and culturally appropriate. I've already mentioned the need for the engagement at the general public level, and make sure that what we're doing is trusted and that we're protecting privacy and data security. And, you know, of course, we want world domination as a leader in genomics. And I think certainly when it comes to integration around a country, we're well ahead of the pack currently, which I'm very proud of. And I'm very proud of, I'll finish on this amazing team of people. And this is just snapshots of a small number of the many, many people who've dedicated their time and their amazing energy and knowledge and expertise to actually make Australian Genomics happen. And I would say Tiff, that you can see over here, and I'm going to hand back to you, Tiff, is the conductor of this amazing orchestra in terms of keeping all the moving parts together and doing it with a great sense of discipline, but a lot of good humour. So thank you, Tiff, and it's been a wonderful session. So thank you all for attending, but I'll just pass back to Tiff for the final word, as usual.
Last word. Kathryn, thank you so much. And I think, you know, we really need to acknowledge your energies and effort in leading and championing genomic research and clinical activity in Australia, you know, over the past 5 years and going forward. So thank you so much for your leadership. Oh, it's so much love in the room. All right, I would like to close by thanking very much our panellists and contributors to today's session. MJ, Steph, Jody, Adam, and Sean. I'd like to thank the team of coordinators and managers and genetic counsellors who have contributed to Australian Genomics over the last 5 years, and very excited to see ongoing work moving forward. And particularly thank you participants to today's webinar. I hope you found it informative and entertaining, and participants and in our research and families who've contributed to our research. Thank you so much. Thank you. Bye all.